Yes, just few seconds, sir. Just few seconds. Yes.
हो मी तिथं पण लॉग इन करतो. एकच मिनिट तिकडेच जाऊ. ऐसे हाथ में पकड़ो मेरे
Good evening, sir. Yes, just few seconds, sir. Just few seconds. Yes.
Nitin, can we start?
So only few seconds, sir. Just few seconds. Few seconds.
Nitin, can we start?
Just 1 minute, sir. 1 minute.
Sorry, type yes.
मैंने किया one time.
So only few seconds, sir. Just few seconds. Few seconds.
थोड़ा सा. Because tablet में.
Yes.
Just 1 minute, sir. 1 minute.
Type yes.
मैंने किया one time. Because tablet में.
Yes.
Sir, kindly be online. We will be starting the session within 30 seconds, sir. Unmute yourself. Unmute yourself.
Yeah, can we start early because I have to go for an emergency.
Yes, sir. Yes.
Hmm.
Yes. 2 seconds. Online, starting session within 30 seconds. Sir. Unmute yourself. Unmute yourself.
Yeah, can we start early because I have to go for an emergency.
Yes, sir. Yes. 2 seconds. Yes. Yes. Very good evening, all. Yes. Very good evening, all. Very warm welcome from myself from Dr. Mateen Sheikh, Secretary of IAP Sangli District Branch, and I welcome you all for today's clinical meeting of Sangli District. And today's basic agenda is regarding celebration of Down syndrome, which is a very special program. And I would like to request uh, Dr. Ramgopal sir to please inaugurate the launch of video which has been done by all of us under the guidance of Dr. Wag sir, or President Dr. Wag sir. Please, please sir, inaugurate the function with opening the video.
Where is that?
Hello.
म्यूट करो.
Yes.
Matin, video started, na?
Yes, sir.
So can I say one or two words? Then I have to rush for an emergency. So on the occasion of Down Syndrome Day, I congratulate Sangli President Dr. Sambhaji Wag and Dr. Mateen Sheikh. Both are doing an excellent work since last 2 years, and you have taken the branch to the new high. And I appreciate that both of you will continue doing the same work, and congratulate on the release of the such an informative video. Thank you, Mateen. Sorry, I have to just rush for an emergency, so I am leaving. Hello. Okay, thank you.
Good evening, everybody. Thanks giving me time for this. I'm genuinely presenting the recent advances in Downs. Downs, we know in 1959 first they found out the chromosome. So basically, why only this 21 has been preferred and to give this Downs a trisomy compared to other presentation in chromosome. So there are a lot of theories has been this thing. Previously, it was thought about transcription that RNA that has the major role. But now slowly it has been proven that messenger RNA has the major role. So messenger, so theory has been put forth that this decoding of messenger RNA can maybe Google has mentioned only name of the drugs, not the No, sir. Vaccine trial. Sir. Sir, its name is ACI 24061 vaccine. So this is actually this vaccine plaque formation. So this vaccine successfully Alzheimer that prevent the delayed like tuberous sclerosis. We have previous drug that is slow the process. Like this, the proven theory has been done in adult patient and in down patient that this vaccine they prevent means patient has aging 10 years. Suppose this is developing 60. Huh? Downs prevent the aging Alzheimer process. Aging Alzheimer process. Suppose down slowly they become the cognition down because of the Alzheimer process. They have the same phenomenon, Alzheimer. So that vaccine is preventing and surprisingly FDA approval also in adult. Not in India, European countries, Alzheimer, last 3 years they are taking vaccines. And they are taking in society also. They are giving into society people also Alzheimer's. India, we hardly know about this. Most of the people going European for medical purpose and taking those vaccines also. That's why purposely put the name of this person, Andrea Piper, CEO. She has put all the study, this thing, research data. I think that is paid PDF.
So, in short, what you wanted to
Yeah.
say is, about even in India,
Yes, sir.
they develop, common man develops
Yeah,
Alzheimer's
yeah.
in a late age.
Late
But
age.
in
Downs, they develop
Downs develop
30 plus,
earlier.
35 plus.
So, to delay that,
Delay that, vaccine is there.
premature aging develops.
Premature,
It has nothing
yes.
to do with avoiding the down.
They don't avoid the down.
Whenever it has-
They don't avoid the down. It's related to only Alzheimer part.
Okay, sorry.
But thus, that success they said that is the 8 to 12% success. That is too much positive study. Yes. Thank you. So we are more counting on the drugs, sir. Pluripotent drugs, agent. That is chromosome conversion, that's conversion theory. So that messenger RNA develop the changes into chromosome, along the chromosome, two changes. So that drugs, if they found out, so we can change the structure of the messenger RNA 21. So I think another 5-10 years will be magic for drugs. Thank you.
Excellent. Thank you so much, sir, for enlightening us for recent advances knowledge regarding the dance. Thank you so much. I would like to request Dr. Shankar sir to please come and felicitate our today's first speaker, Dr. Mahesh Sale, sir. Thank you. Thank you so much. Now proceeding further, I'd like to request today's second speaker, Dr. Kumar sir. Yes, sir, we all know him very well, a great academician. Sir is HOD Pediatrics from Bharti Hospital. My big brother. Yes, I'd like to request him to and give the session further.
empty म्हणतो स्कॅन हां
लॅपटॉप
घेऊन येऊ
त्याला अटॅच केलं माझं ओपन
सर मी ते माझ्या पेन ड्राईव्ह मधून इकडे गेलो आणि झूमला कनेक्टेड आहे
तेच लागेल
तेच लागेल म्यूट करत होते. हे ना. मी घेतो. हे पण वर्ग हे आहे.
Good evening, everyone. आवाज कसं काय? असू दे. Okay, I'm going to present again a simple case, not that much complicated from PG point of view, again important. So I'm going to present from again students' point of view. Okay, I'll start with the case. It was an 11-year-old female, third issue of second degree consanguineous marriage, residing in Jivargi, district Kalburgi, Karnataka state, Hindu by religion, was referred from a private children hospital with chief complaints of fever on and off for 4 months, chest pain for 3 to 4 months, abdominal pain since 4 months, and not gaining weight for last 2 months. So these were the complaints for which the patient was referred. The child was apparently asymptomatic 4 months back. Then she started complaining of fever, which was of insidious onset, moderate grade, not associated with chills and rigors. The fever was coming around 1 or 2 spikes per day. It was temporarily responding to oral medications on showing to local practitioner. The fever was on and off for almost 3 to 4 months. It was remaining for around 6 to 8 days. Then it was subsiding with treatment. Until she used to take oral treatment, the fever is too less. But once the treatment was stopped, again she used to get the fever. For these complaints for the fever, the child was admitted in the private hospital in Kalburgi for twice or 2 times over a period of 3 months, and I had received treatment in the children's hospital in the form of IV saline, injections, oral medications, with some temporary improvement in the symptoms. But after discharging the patient to the home, again within 2-3 days she used to get the fever and others associated all symptoms. So it was not totally getting relieved. Last 15 days before this admission into Bharti Hospital, the fever became more persistent, 2 to 3 spikes per day, and was not responding to treatment, for which the relatives they shown to some Kalori hospital in the mirrors. From there, the patient was referred. to Bharti Hospital for further management. The child was also complaining of chest pain for 3 to 4 months, which was of a more of a left-sided, more in the left lower region, left lower region, that is in the chest and maxillary region, continuous, more with respiration. It was associated both inspiratory and expiratory phase, without diurnal and postural variation. Again, the pain used to come down with the fever. Whenever the fever medication used to receive, the pain used to subside. But again, when the medication used to get relieved, the pain used to be again used to come. The fever was also associated with dry intermittent cough without expectoration for almost 1.5 to 2 months with fever, and the cough was still present. There was no any diurnal variation as far as cough was concerned. There was also history of abdominal pain for 4 months, which was dull aching continuous. It was more around the umbilicus with waxing waning in severity, which was also getting relieved by the same medication what the medication used to get, but the abdominal pain was persistent. After relieving abdomen means medication is to wane off. For last 15 days, there was also history of breathlessness, which was associated with chest pain, abdomen pain, and intermittent vomiting, for which the patient again was shown to Kalvari Hospital, from where the patient was investigated there. Some blood test, X-ray, USG was done, and the patient was referred to a pediatrician, where in view of some left-sided lung pathology. And from where the patient was referred to Bharti Hospital for further detailed investigation and treatment. This was the overall picture. Means there was very vague symptoms were there, very non-specific symptoms were there, and the patient was otherwise okay. He was not bad, deteriorating part, but the symptoms were there. So we tried to go for the negative history. There was history of weight loss was there in the last 2 to 3 months, around 3 to 4 kg. There was no history of ear discharge, headache, vomiting, no history of loose motion, constipation, blood in stool. There was no history of palpitation, breathlessness, joint pain, joint swelling. There was no history of rash or body, no history of hematuria, oliguria, burning, urgency, frequency of micturition, no any urine complaints. There was no history of cox contact in the family. There was no any other symptoms also suggestive of tuberculosis in the patient. No history of jaundice, no history of constipation, no history of convulsion, altered sensorium, or any symptoms suggestive of focal neurological deficit. For all of the symptoms, the patient was admitted twice in Karnataka. Has received temporary medicine, but again the patient symptoms used to appear. Some investigations were there done. USG abdomen was done around 2-3 times. First USG was done on the 16th of October. That time this was the picture what we got: non-specific mesenteric lymphadenitis. There was no hepatosplenomegaly. Kidneys were normal, pancreas were normal. No any ascites or a few mesenteric enlarged lymph nodes were visible. This was the CBC report, which was available with the patient done on 2nd of March. In this, there was anemia was present, 10.2 gram hemoglobin. WS count was appeared to be in the normal range with little bit mild neutrophilic predominance. ESR was raised. ESR was 65. Random blood sugar was normal. His Vidal test was done. It was positive, 1 in 320, 160. So most probably he has received treatment for that on and off. Some improvement was there. Again, the sonography was repeated on 2nd of March because of the persistent abdominal pain was also the symptom here. Persistent abdominal pain was there along with left side chest pain. Again, the repeat sonography which was done didn't show any hepatosplenomegaly, gallbladder, pancreas appeared to be normal. There was minimal free fluid in the pleural cavity. This was on the 2nd of March. So the impression that time that was given was a mild pleural effusion with no specific any abnormalities were found. Then again the chest X-ray was done on 3rd or 4th of March, which was showing blunting of CP angle, which was obscuring the left lower zone, suggestive of left-sided pleural effusion. That was one additional picture what was got here. This was the X-ray which was done. Anybody can see, read the X-ray. If you see the X-ray, there is some homogeneous opacity is present in the left lower zone. with some amount of, you can see the shadow also. Shadow was little bit odd for me. When the patient, I saw that shadow, which was little bit odd for me to make the diagnosis. So I thought this is something odd. I should refer the patient to institute and try to find out the etiological cause. So I referred the patient to Bharti Karnataka patient. I try to counsel them. So we'll try to do a proper workup so that we can get. Definitely, I was suspecting more of a chronic etiology in this patient. Something odd was present. So again, I referred the patient for further investigation, further,
You can see the air also in the left CP angle.
Yeah.
It is not clear that if you
Definitely. So yeah, that's what made me to think in this patient what was, you can see this angle. Yeah, the shadow is more convex on the left side. What we expect when the something is there on collection, we expect a concavity. And it was a homogeneous. There was no air, bronchorum, nothing was. It's a very homogeneous opacity was visible. So I thought this is little bit odd for me as a routine pediatrician to directly start any management or anything. So I referred this patient to Bharti. Past history, there was no any significant history. Family history, again, there was no any history of tuberculosis, jaundice, asthma, or any infective condition in the family. Birth history, again, it was a full-term normal delivery, tried in birth. Birth weight was 3 kg, full-term, no NICU admission. There was no any post-term any admissions also. There was no any history of recurrent infections and anything in this patient. Immunization was up to date as per national immunization program. Development in the child, that girl was normal. Again, she was studying in 6th standard. Average in studies. On examination, anthropometry wise, she was 12 to 13 years. Weight was 26 kg. Expected was 35, and it was falling around 10 to 25th centile. Height was 139 centimeter. Expected was around 143 to 145. Again, it was around 25th centile. BMI was 14, so it was coming below 16. So it was little child appeared to be undernourished. So on examination with the patient, we referred to the Bharti hospital. On examination, the child was conscious, oriented, little sick looking, cachexic, poorly nourished, febrile at presentation. Heart rate was 110 per minute, respiratory rate was 30 per minute, definitely 12-year child rate 30. Well, there was tachypnea present. Because anything with about 10, 12 years, if it is more than coming around 18 week or 22, we said that there is an increase of fast breathing is there. Some pallor was there, moderate pulmonary pallor was there. SpO2 was 96% at room A. SpO2 was maintaining. Blood pressure was 100/70. There was no interest, no clubbing present. There was no clubbing. Bilateral small cervical multiple non-tender around 1.2, 1.5 centimeter lymph nodes were bilaterally palpable. There were no any axillary inguinal lymph nodes significantly palpable. This was what we got on examination. No pedal. JVP normal, not raised. RS examination, air entry absent. There was, when we auscultated the patient, air entry was almost completely absent in the left lower axillary, mammary, left interscapular and infrascapular region. There were no any crepitations or bronchial breathing heard around the same area or on the other sides of the auscultatory areas. Cardiovascular was audible. There was no murmur, no tachycardia present. Per abdomen was soft, non-tender. There was no any obvious abdominal distension present. There was no organomegaly. Liver was 2 cm palpable below left coastal margin. Again, liver spine was around 7.5 to 8 centimeters. So there was no hepatomegaly. There was vague periumbilical tenderness present in this case. There was no clinical evidence of ascites. Normal peristalsis were audible. CNS, again the girl was conscious, oriented, no neck stiffness, plantars were flexor. There was no neural deficit or no any focal deficit was present here. So this was the view what I got on the examination. So for me also it was, when I admitted the patient, it was very difficult to proceed further what is exactly happening, because the history was for 4 months. So whether it was a continuous history, it was a little bit on and off vague history. So at that time we kept a working diagnosis of left-sided pleural effusion with failure to thrive with anemia. Etiological, most probably again Karnataka patient, little bit from low socioeconomic status, repeated history, fever, and some collection present. Unilateral, as what we have learned in our process, unilateral left side or any side effusion which is painless, not rapidly progressing, We usually suspect tuberculosis unless proved otherwise here. Same thing was in my mind also. And with that we admitted the patient, or that because only one thing was the shadow was not matching with that effusion or collection, but that was little bit odd for me. And also fever was there on and off. Entry because the Vidal was positive one test outside, so we kept that option open here. But again, Vidal cannot remain. That fever cannot be there for 3 to 4 months unless it's a complicated entry, or she will go into some life-threatening complication. Again, it was a slide test which was done. If I can read that, it was a slide test. So again, we don't give any value to the Vidal test if it is a slide test. Otherwise, we should have some confirmatory test for that. So this was our working diagnosis what we have kept. So we tried to investigate the case. Patient was admitted on 4th of March with us. Again, the hemoglobin was around just 9.1, around 9.4. W score was normal. Lymphocyte 40%, platelet was normal. QCRP was 0.4. Quantity CRP was negative here. ESR was raised again. In outside report also raised. Here also it's 23. RFT was normal. Sodium potassium was normal. X-ray, we reported the X-ray again. It was showing some left, what it was seen by radiologists, some senior, they said that maybe possible left subpulmonary effusion possibility. That was what it was given. Again, the trachea was, and you can see, I'll show you the next X-ray, then you can see. Urine routine was normal, stool reducing substance normal, it was stool, didn't show anything, open blood was also negative. Yeah, definitely. That was something was making me a little bit odd in this case. There was some, so either there is a collection, if you massive collection that will cause shift. A small collection cannot cause mediastinal whole shift here. Now this was the X-ray which was repeated, where the little bit you can see the heart shadow was shifted to the right side. Again, the shadow was same. For me, what was worrying was that that diaphragmatic border, that was not matching. Yeah, what we expect if there is a collection, we should have concavity upwards. Here again, you can see that it is more of a convexity upwards in that this X-ray also. So we went for UAG. We did UAG of this way. Again, some investigation was done. Again, LFT was normal. HIV, SBHG was negative. We did some systematic investigations also. Serum ferritin normal. LDH was 142. CRP negative. Calcium phosphorus, magnesium normal. Urine was also normal. There was no any effective focus. Albumin was just 1+. Vidal Brucella test negative. Induced photo was sent for AFB. Gastric aspect was sent. Again, AFB was negative. Culture was also sent. Induced photo from tuberculosis point of view. Again, for me, first diagnosis was the tuberculosis, what we were suspecting. It was very my sincere effort, whatever I was expecting. So I kept as a tuberculosis. We sent that. We did again chest UAG. That this was on day 1, everything. So immediately we did the chest UAG. Other investigations were done on day 2nd and day 3rd, all the systemic investigations. It picked up there was a left-sided massive pleural effusion. Even the effusion was not appearing big on X-ray. But on chest side, chest UAG, there was a massive left-sided pleural effusion with underlying lung collapse consolidation, left lower lobe. So we decided to go for tapping here directly because the child was a cold case. There was no breathless, he was not toxic. We were not suspecting any empyema. So we did a tapping here. And it was a very dark reddish colored aspirate was there. Little turbid it was. Not it was a straw color. We usually as for tuberculosis we expect it should be a little bit light or it's a straw yellow colored fluid what I was suspecting. But it came to be a reddish colored turbid fluid little bit. So we sent it for the biochemical analysis. Proteins were 2.5 gram per ml. Sugar was 94. Total WBC count was 50. It was again lymphocytic predominance. It was 80% lymphocyte, 20% polymorphs. LDH was little bit raised, 810. Around 50 ml of fluorine fluid we tapped at that time because it was a turbid and little, it was not so we drained as much as possible that time. So around 50 ml was removed. We sent this fluorine fluid for CBNet. Again for me still it was hemorrhagic T. We keep all fluorine fluid or T. Either it's a trauma, tumor or tuberculosis. If it is a hemorrhagic color fluid we say. So we try to again suspect that tuberculosis. We CBNet also pleural fluid was sent. That also after 3rd 48 day it came negative. Induced photo was sent for AFB again for strong suspicion that too also came negative. Now this was the color, means the pleural fluid which was drained. Initially we took the sample in the syringe that we sent for cytology biochemistry culture. The extra fluid that was pleural fluid that was drained, it was almost dark red color. So again, as the symptoms are vague, we are not getting diagnosis. Then supportive therapy was started. The child was admitted in a high dependency unit. O2 was started 2 liters initially on day 1, day 2. Baseline antibiotics was started. Sub treatment oxygen was started. Then we started monitoring. On day 3 we repeated the again X-ray. When the X-ray was repeated, the shadow was same. There was no decrease in the collection site. So again we went for tapping. So again 200 ml of reddish colored fluid was drained. Almost 200 ml this time, and it was coming very freely. It was coming very freely, 200 ml of fluid. Almost second and third time also, then when the fluid came, then we suspected something we are missing. There is some pathology, underlying lung pathology in tumor. So we planned for HRCT chest in view of this persistent collection to see the lung parenchyma status. It showed again a massive or a gross left-sided pleural effusion HRCT with underlying collapse consolidation of the left lower lobe. There was no any significant lung pathology or any rib pathology was picked up even, sir. So the X-ray, sir, again this was the third X-ray we took. Even after draining 200 ml of effusion, X-ray was coming, sir, like this only, sir. The sides and that it was not getting changed again. Now we repeated on the third time, we repeated on day 8th of March, on 5th day. Effusion, even after tapping, it was increasing in size. But some amount of the midline which was present little bit decreased. This was on the day, means for 12th of March X-ray, March. Almost we did drain the effusion, that blood stream fluid for 5 days continuously. And every day used to get around 150 ml to 200 ml of drain, very free flow.
Was it again red or white?
It was red. Color was not changed. It was a reddish color. The darkness was little bit decreased, but it was reddish color. No, that was little bit missing. We did this. We suspected that we were suspecting tumor also in this patient. Malignancy hai kya? This. It was no. It was reddish color. It was not. It was little bit turbid. It was not frank pus. There was no pus was there, sir. Video चालू होत नाही म्हणजे हे तो होतं त्याच्यावर घेतलंय त्यामुळे व्हिडिओ आहे सिटी स्कॅनचा. It was not prevalent. The W score was only 50. CT scan, which has gone further. There was a massive collection. You can see the collection was more on the posterior aspect. The whole collection was more on the posterior aspect, and it was going further, and that was compressing the again this mediastinal part. So pleural tapping was done here for almost repeatedly for 4 days. Where around 150 to 200 fluid was done. It's very difficult to also again to reach to the etiology. What was that? Tuberculosis almost tried from all aspects. Everything came negative for tuberculosis. So possibility of malignancy tumor was again suspected here. HRCT we done. It is accidentally picked up. There was an intraductal calcification in the pancreas. Then what next? The effusion which was collecting was on the posterior aspect of the lungs. It was more on the inferior aspect. No, that was when then we tried to plan for this, what we said. Then with suspecting some whether there was any abdominal pathology which was causing that, because HRCT didn't pick up any lung pathology here. So we planned for HRCT here, abdomen, which picked up an atrophic pancreas with multiple intraductal and intraparenchymal calcifications. So then retrospectively we sent the serum amylase and lipase here, and by surprising it, the lipase and amylase both was raised here. It was suggestive of some amount of pancreatic inflammation. Maybe acute pancreatitis was ongoing process. But the patient was having very chronic symptoms, so that we didn't suspect any pancreatitis. And 2 times the USG abdomen was done, it was normal. So HRCT was done, it was reported by Nikit Mehta. Sir, again, this was again, it's not getting opened up. This was the HRCT report, abdomen, moderate to gross pleural effusion of the left side with left lower patchy consolidation segmental collapse. Pancreas, main pancreatic duct was dilated almost 7.6 mm. Pancreatic was atrophic with multiple intraductal and intraparenchymal calcifications were present. Largest measuring around 17/12 mm in the body, unseen torso region. Multiple thick pockets of hyperdense collection in the peripancreatic location along the head, pancreas, and tail region were measuring. The largest measuring around 38/16 mm along the uncinate region. There are also pockets of thick collection, they were present all over the pancreas. And the final diagnosis what was here for this was given was that there were calcifications all over the pancreatic tissue, intraductal and outside the duct also, where the possibility of sequelae of chronic calcific pancreatitis with pseudocyst showing mass effect. So this was what we got on the HRCT, that there was an associated chronic calcific pancreatitis with pseudocyst with multiple pockets were present in the peripancreatic region. Now, there were now 2 pathologies with us. One was on the lung and one was on the pancreas. Whether the both are of same etiology or they are different and isolated. So now, and whether the pleural pathology, what was the collection we were getting, was the primary or it was a sequelae of pancreatitis. So we went for the pleural fluid amylase, what we suspected. And to our surprise, that pleural fluid amylase level was 4,956. It was very much raised. Pleural fluid LDH was 810. Again, it was raised. Normally, when there is an acute pancreatitis chronic, we expect there is some reactive effusion is there usually on the right side or left side. But that is usually a serious colored. And it will not accumulate so rapidly, sir. That was a little bit difficult, surprising for us. Because when you should drain within 12 hours, it was getting filled up. If it is reactive, you should not fill up immediately. No, it will require some time. Even if it is acute pancreatitis. Here the refilling was happening and it was reddish and turbid in color. So what was the main cause of pleural effusion? Recurrent it was. So amylase this again it was raised. So we suspected that there is some, mostly it is that effusion is secondary to the primary pancreatic pathology. But that huge amount and reddish color made us to, so again we consulted the gastroenterologist also and we interventional radiologist. Both of them worked up on this case and they kept up a very high possibility of fistula between that pseudocyst which was formed with a thick collection may have formed on the posterior aspect, and that was causing shift of fluid from the pseudocyst towards the left sided pleural effusion. That was only one possibility because the amylase was very high and it was again turbid in color. The patient was started on this symptomatic therapy, pan lipase and other things were all replacement therapies were added. 3-4 times he told, gastroenterologist told that you drain it for 4-5 days continuously. We drain every time it was coming 150 to 200 ml. After that he said, now you wait, don't drain it, will you monitor the patient after 15. Otherwise the child was absolutely okay, there was no any other issue. And then he told that if it is persistently coming out even after 15 days, you can go for surgical intervention. Either go for the open laparotomy, find out whether there is any fistula or thing, or go and along with that you have to plan for ERCP also for the intraductal stenting and removal of the calcium stones. That was what was the plan told us, and the patient was, as he was okay, symptomatically better. After 4-5 days, some drain was little bit decreased. We discharged the patient with the planning. So the patient is going to come on follow up. Only what problem what we had was faced was the USG reports. We had 2 USG reports in the last 4 months which were given normal. Whether it was picked up properly or not, again that was the issue for us. No, it was not operated. It's going to come on follow-up. No, not going. Patient was asymptomatic.
When the report came at pancreatic,
Yeah.
the fluid is coming from the pancreas.
Yeah.
It is absolute, right?
No, we are not going. So our final diagnosis, what we kept was it was case of acute and chronic calcific pancreatitis with this pseudocyst with left-sided recurrent hemorrhagic pleural effusion, possibility of pseudocyst to left pleural cavity fistula. And we have kept up because that collection was little bit difficult. Possibility of fistula was kept very high from the interventional radiologist and gastroenterologist point. Still, this case is open, which we have not got the complete diagnosis. Possibility, closest possibility.
Clear case of fluid in the pleura because of acute pancreatitis.
Yeah.
And as you said, pancreatic secretion they spread very fast because they contain enzyme.
Yeah.
So it's an active process.
Yeah.
It's not like pleural effusion.
Yeah. Yeah.
So it's an active process. All the enzymes are there. They will rise all the barriers.
Yes.
And they will go very fast.
Yeah.
And this patient needs the ERC to be stented.
Absolutely. That's what we have planned for ERCP and stenting part. What is said now? The patient is going to come follow up on this part.
Yeah, we can do contrast.
Because the affordability issue was there with this patient, again the cost was little bit high.
Fluid is getting collected within the only fistula can explain. Otherwise, ascites can also find.
Absolutely, that was what we have strong possibility of fistula was kept here in this patient because it was again thick colored fluid, hemorrhagic fluid. If it is a plain straw color, then we can explain it's just a transit detour or it's just a reactive collection.
Sir, even autoimmune pancreatitis should be thought in this case. So it is the
See, we have not found out the etiology. Again, there is some maybe a congenital etiology. We did that's why we did this calcium chloride ratio, hypercalcium, all things. They come to be normal. Maybe a congenital process may have started. Very difficult. It was whole pancreas was full of calcium stones here. Almost it was replaced by calcium.
But when we say chronic pancreatitis,
Yeah.
the levels of amylin they don't think that it's acute pancreatitis.
That's why I said no, it's acute or chronic pancreatitis. Calcium will explain the chronicity, and then enzyme levels will explain the acute pancreatitis. So we'll see if the patient is going to come on follow-up, we will come to. But little for me it was little bit odd when it presented with all features. That X-ray finding was little bit very odd for me. That was causing all confusion and other things. Yeah.
There need not be any anatomical connection between the
Absolutely. Yeah.
There are minute connections from
Yeah.
where the fluid will go.
Yeah.
And you might not find it on table if you explore.
Absolutely.
There will not be any fistula as such.
Yeah. So that's why even gastroenterologist said that major treatment should be here intraductal ARCP and you have to go for stenting in this patient. So to relieve so that back pressure changes what is happening. That will get cleared up. Thank you.
Thank you, sir. Thank you so much for sir. Wait, sir, please. Actually, true academicians, as he himself proved, this is a very challenging case, and
Because really initially we thought as a tuberculosis,
Yes.
unless we said day one I said it's
Exactly.
unless it's a tuberculosis.
There was chronic pain abdomen.
Yeah.
One single serum amylase. Initial पहिला 4 मध्ये काय तिकडे होतं पुढं गिवन अप्रूव्ह.
UHG was done twice.
That's not what I said. Ultrasound can't pick up pancreatitis. Will not pick up pancreatitis. It is a retrograde organ.
That's why this patient, no, when the patient come to us, it was the lung pathology. Patient presented with lung pathology and abdominal pain was a very vague non-specific symptom when it came to us. That's why the patient was rending here and there for last 4 months. He was going. That's why within almost 4 points, the collection was little odd for us. What was that?
Failure to thrive
Yeah.
was one indication.
Yeah.
Failure to thrive, which we see in chronic pancreatitis.
Yeah.
But
That-
again, we can see in
Tuberculosis also. So all features were combined for chronic pancreatitis and so tuberculosis also. So we are thinking from that point.
So he's an.
the 4 months of
Now if patient is going to come on follow, we'll try to do work for the etiology. What is the cause of that calcium pancreatitis?
It's on and off
Screen
for
share
4 months.
correct.
So fever itself it is non-infectious fever.
Yeah.
So we got a pattern in this children.
For me, the patient presented as a lung pathology. My worry was with the lung pathology. There was no other feature.
Before jumping to autoimmune, first we should rule out anatomical abnormality.
Absolutely. So I went from the anatomical sides here. So I have gone through sequencing. So that is etiology. That we have a concern with the first, where is the pathology? We have picked up pathology, then primary lesion. What is the lesion? What has primary lead to secondary? So we have went up to that. Now then next we'll think of the etiological part. And
6 years.
To 13 years.
COVID, was there any COVID?
No, we didn't had any history. Maybe post, but calcification there is maybe post. Keratin normal आहे सगळं normal आहे ऍटलीस्ट थोडंसं ह्याच्यामध्ये रेंज होतं फक्त. Thank you.
Thank you. Sir, wait, sir. No. Take one more, please. I really thank Dr. Kumar sir for presenting such challenging case. Yes, I'd like to request Dr. Vats to please come and consider, sir.
Guys.
Going further, thank you, sir. So going further, I'd like to request our next speaker, Dr. Umbarkar sir, please be on the dais and continue session.
Thank you. Good evening, everyone. So again, I'm presenting a simple case which caught me in a surprise. So, he's a patient who was a 3 years and 9 months old boy. He came to me with periumbilical pain, dysuria, vomiting once in a while, but there were no any acute abdominal symptoms. In the negative history, there was no history of hematuria, no umbilical discharge or no melena. There were no acute abdominal symptoms. There was no green vomiting or abdominal distension. There was no history of TB or TB contact or contact with a pet at home, and there was no failure to thrive. On general examination, he has grown well. His anthropometry was okay. Weight was 14 kilograms. Height was 98 centimeters. Vitals were within normal limits. No cyanosis, ictus, clubbing, lymphadenopathy. On local examination, abdomen was soft, no distension. A lump was felt at around the umbilicus with mild tenderness. Bowel sounds were present. No guarding rigidity, no umbilical discharge. Bladder was not palpable. The baby had a physiological phimosis. Other systems were normal. So here's a boy who came to me with periumbilical abdominal pain, dysuria, and occasional vomiting. Stable child. And on the examination abdomen, there was central ill-defined lump was present. So I thought systems which were involved was either abdominal system or urological system. The lump which was there in the abdomen, maybe it was coming from the bowel, like any cyst or etc. Or it may be coming from mesentery, like mesenteric cyst, or from urachus, like urachal cyst or patent urachus. So he was worked up. Hematologically, he was normal. Biochemically, he was normal. Ultrasound which was done, you can see that an approximate 37 by 33 millimeter cyst with few internal echoes is seen in the umbilical region. No internal vascularity, very duplication cyst, very urachal cyst. A CT scan was done. You can see that this is the umbilicus, and there is a well localized mass which is seen protruding inside the umbilicus, and there is a doubtful communication with the bladder. This is a urine examination was normal. This is the transverse section. Again, you can see there is a big mass at the umbilicus, but in the transverse section, I couldn't demonstrate this continuity with the bladder. So a CT scan was reported as a well-defined, slightly thick-walled cystic lesion in the umbilical region, bulging into the umbilicus, abutting small bowel loop, then mesentery, with enhancing walls, internal echoes, and debris, consistent with infected urachal cyst. Possibility of mesenteric cyst is less likely. So ultrasound also suggests it might be a urachal cyst, and CT said positively that it was a urachal cyst. Okay. So surgical plan was to do an exploratory laparotomy and excise the urachal cyst. Okay. Experimental laparotomy was done by an infraumbilical incision, and you can see that there was a Mahesh diverticulum. It was not a urachal cyst. There was a Mahesh diverticulum with a large cyst which was attached to the umbilicus from inside. So it is again from another view. You can see that this is a Mahesh diverticulum, and it has attached from inside to the umbilicus. Okay. Now this is the Mahesh diverticulum. When I disconnected it from the umbilicus, there was a cystic malformation which was present at the tip of the Mahesh diverticulum, and it was attached to the umbilicus from inside, and that this was picked up as a urachal cyst. And purposely I said that this is a special vessel which supplies blood supply to the Mahesh diverticulum, that is called as the mesodiverticular artery. And this artery is separate, and you have to ligate this artery before removing Mahesh diverticulum. Okay. So again, I did excise the Mahesh diverticulum. There are two things to note here. Please note the bowel clamp which I have applied across, and the mesodiverticular artery was ligated. So excision was done. You can see again this suture points to the ligation of the mesodiverticular artery, and this is the bowel clamp, and this is the removed Mahesh, and the intestine was closed. This is the post-op picture of the baby in the operation theatre. You can see that I took a infraumbilical incision thinking it to be urachus, but in fact it was a Mahesh diverticulum. So all went well. The baby was shifted to ICU for observation, and post-operative period after 8 hours after the surgery, in the morning the baby passed a large amount of melena, huge amount of melena. Okay, and this case I did around 6 p.m. in the evening, and early in the morning the baby passed such a large amount of melena. Within 2 hours, again he got a very large second bout of hematemesis. I mean melena, fresh blood, and after till by 12 hours, this is a third bout of melena that the baby passed. The baby pulse rate was around 130, BP was by around 100. Not any evident shock, but tachycardia was persistent. Okay. 3 bouts of heavy melena, the baby passed with fresh air, but rise tube aspiration was clear. Patient had tachycardia, but no clear-cut features of shock. Hemoglobin level, which was 11 grams pre-operatively, has dropped to 6 grams. So this was an acute shock, acute anemia, and there was bleeding from somewhere. You can see that the hemoglobin has dropped to 6.4 grams. Just after 12 hours after surgery, there was bleeding from somewhere. It was a Sunday. No laboratories were open. Okay. So I had to look from where the bleeding was coming. So the patient was stabilized, injection pause, everything, blood transfusion again. The patient was taken up for surgery. Okay. This is the second surgery in 24 hours time. You can see that this is the previous anastomotic site, which looks clear. There is no any evidence of bleeding outside. Okay. Only thing you can see is that this is the distal wall, which is a little dark because there is intraluminal blood. This is a colon again, which is dark there because there is the intraluminal blood there. The proximal bowel looks normal. You can see that this is the distal bowel, which has got a dark blood inside, and this is the colon, which shows darkish color because of intraluminal blood. Okay, so I did again what I thought was the bleeding may be coming from the anastomotic site inside. So I again did a local resection, but there is a video which I cannot show. The mesenteric vessels were pulsating like anything, as if the baby has got a mesenteric hypertension. Okay, maybe because of shock, we don't know, but his BP was well maintaining. Actually, the video I had desktop वरती दाखवतो. But the mesenteric vessels which were here, they were pulsating like anything. And when I removed this bowel clamp, there was spurting which was occurring from the bowel ends. So I had to literally cauterize the entire bowel ends. I had a fear that if I cauterize it, it might not heal, it might leak. But then also, actually, you can see that I have just sort of compressed the bowel, no mesentery. And there was a lot of spurting which was going on from the mesenteric end. So I cauterized it, both the bowel ends cauterized, and then I did an anastomosis. Okay. So the baby did well. This is the completed anastomosis. Video is not playing. And this is the second anastomosis. Okay. So So course after second surgery was uneventful. The baby continued to have a mild to moderate rectal bleeding, but that was collected because I milked it on the table, and but the baby settled on. He was vitally stable throughout the postoperative second operation. Oral sway started on third postoperative day, and he was discharged on fifth postoperative day. So I got his prothrombin time, APTT, and fibrinogen levels, but they were normal. So there wasn't any bleeding disorder as such. There was no previous history as such. Okay. So what was the problem here? So here the problem was it's an acute GI bleeding in a post-operative period after a GI surgery. This problem I have never seen in pediatric age group. There are case reports, many reports which are reported in adult population when they undergo surgery for GI malignancy. But in pediatric, I don't have any report. So what is the second explanation can be the bleeding is coming from the ectopic mucosa. We all know Meches diverticulum may have a gastric or pancreatic mucosa, but usually when we excise the Meches, that is why we do a wide excision. Okay. So secondly, the bleeding can come from the Meches in ectopic gastric mucosa, but this bleeding usually it manifests in the pre-operative period. The patient may be having some melena. This history was not there. Sometimes the Meches bleeding can be also with acute blood loss. Both these conditions were not there in this particular case. So third thing which remains is this mesenteric hypertension. So localized loop or bowel will have an increased blood flow, and that might cause a bleeding in the post-operative period. So out of these three, I think the third factor may have played a role in this particular, but there is no way I can prove that. Okay. Now this is again the same slide which I have just shown you some minutes ago. You can see that this is the bowel clamp. This is the bowel clamp, and ectopic mucosa site is usually at the junction of the Meches with the ileum. So in the first surgery, I have taken care that I had included that particular part in the first surgery itself. But when the patient started bleeding, I thought whether have I left any ectopic mucosa. That is why I second time I entered and I removed a local resection and anastomosis. So this factor is also not there that the bleeding was coming from ectopic mucosa. This is the histopathology of the first Meches specimen. It says that no heterotopic elements seen. That means in the first surgery was done perfectly, the excision was sufficient, and there was no any ectopic gastric or pancreatic mucosa. And second time, when I removed the bowel segment, you can see that ileum with congested blood vessels with no heterotopic gastric mucosa is seen. So at the end of this case, I don't know from where the bleeding has come. The cause of bleeding in this case, for me at least, it remains obscure. Most likely it is maybe because of mesenteric hypertension. I advise the patient to go ahead and do a radionuclide scan and RBC tagging, but the patient said, "We're all right. We don't want to do any further investigation." So at least I haven't seen such a case after surgery. Meches we see bleeding we see before surgery because of ectopic, but after surgery within 24 hours, I have never seen such a case. I would like to have your opinion on this case. Thank you. The transfusion was given immediately after the second bout of melena. After that, no. This case I did in February, but after that, not a single episode of melena. Nothing.
Sir, what about sometimes enterotoxic E. coli may present like this?
Okay.
Some infectious pathology in the abdomen.
Okay.
It's a kala masala enterocolitis.
But that baby was not that toxic. And when there is a positive history of surgery is there. Yeah. It was. Yes. It's active. It's acute anemia. It's active bleeding. Yeah, so it's possible.
I was having one case. Child with CTMR was admitted for LRT, taking out the Bharpuri. Child started settling down by day 5. Day 5, frank melena pass करो.
Okay.
Child was not at all affordable. मात्र तो देते ही नहीं. Melena म्हणजे एवढा melena की I got panic.
Okay.
So I shifted it to Bharti. It turned out to be E. coli. Blood
Okay.
culture showed E. coli. Diagnosis was E. coli toxic induced septicemia which was positive.
Okay. But when I opened this patient up in the middle of night, almost infected, I had sort of a feeling, if I don't find anything in the abdomen, what am I going to do? What am I going to do? Because after opening, there was no any bleeding anywhere outside. It was in the lumen. So what I did is I excised the 5-6 centimeters of the ileum, which was adjacent to the Meches diverticulum. Suppose if that had not stopped the bleeding, then it was that way. It was a very tricky case for me, and I haven't seen such a case in my surgical practice. Small bowloscopy is a little difficult. Large bowel, so colonoscopy we can see some 5-6 centimeters of ileum, but this is almost 2 feet proximal to ice. That's what we say. No, it is very difficult, and in spite of when there is active bleeding, the even endoscopy will not help you. From where are you going to look for the source of the bleeding?
It was bleeding. It was the only choice was the laparoscopy.
Yeah.
Because with that bleeding, you cannot wait.
No, you cannot wait. You cannot wait.
Stop bleeding and go for expert laparoscopy.
Yes.
Yes, pulsating, severely pulsating mesenteric arteries.
Yeah.
Has to be explained somewhere.
Yeah, yes. That is why I did a lot of sort of research. I mean, the literature, but it is not mentioned in. तसं काय नाही ना. That is another possibility, sir. It had diverted the blood flow to the remaining arteries. Yeah. The clamp is operating only the bowel. You can see that. The pulsations you can see, sir. It is almost throbbing pulse. You can see here. And I have operated only the bowel, not the mesentery. Thank you. Thank you.
Excellent case, sir. Actually, I have played Dondon Shadoway Matakana, I'd like to request Dr. Srinath sir to please come forward and forward and solicit Dr. Bagas.
I just got a message from particular format as advised by but is it really practical? One. And second, in every meeting, is it practicable to have a moderator? Opinion is open. So is it possible?
You can do as you were doing previously, but what only we try to standardize the things.
But is it compulsory?
Once in a while, sir. Once in a while, we can just have this for.
Yes, if you have to present 2-3 cases together, it's impossible.
2 cases, more than 3
Starting with age, sex, and then address.
Shortly, brief.
You can do it briefly, 3-4 slides. You can just do 3-4 slides.
So else, what we can do, what I can suggest, if when PGs are presenting, they can present in that format, and that we can record. And
One case we can do like that. Other 2 cases we can do
Yeah.
practical.
There's a lot of negative points. Suppose you start at least 45 minutes.
Positive points.
Just
Slides.
Just touch upon the positive points.
Yeah.
You can project this slide and then say only these are the positive points.
Yeah, sir. Agree. Thank you.
Thank you so much for suggestion, sir. And actually, we what we are trying here, we want the PG students to know what they are doing, what they will go further. Yeah, अपने पास जो आएंगे, not in market, but they'll come in their in their own private practice. They will know what problems they are facing right now. This is for the lecture and for them to know what's going on actually. Yeah. I would like to as we are lagging behind, but still I would like to show the video which we made and at prior there was less attendance. I would like to show the video again, please.
मार्च हा वर्ल्ड डाउन सिंड्रोम दिवस म्हणून जगभरामध्ये साजरा केला. 46 गुणसूत्रापैकी 21व्या गुणसूत्रातील दोष व विशिष्ट भाग दर्शवण्यासाठी याबाबत जागरूकता निर्माण करण्यासाठी जागतिक डाऊन सिंड्रोम दिवसाच्या निमित्ताने समाजात जागरूकता निर्माण करण्यासाठी आम्ही IAP सांगली डिस्ट्रिक्ट ब्रांच मधील बालरोग तज्ञांनी हा व्हिडिओ सादर केला आहे. मला खात्री आहे आमच्या ह्या प्रयत्नामुळे समाजात डाऊन सिंड्रोम बद्दल जागरूकता निर्माण होईल व आपल्या ज्ञानात नक्कीच भर पडेल.
नमस्कार. डाऊन सिंड्रोम मूल जन्माला आल्यावर तिच्या बाळाच्या स्त्रीमध्ये गर्भात असताना प्रतिबंध केला जाऊ शकतो, म्हणजे निदान करून आपल्याला समजू शकतो. 700 पैकी एका बाळामध्ये 21वा नंबरवा क्रोमोझोम 2 चेहऱ्याची 3 जोड्या निर्माण झाल्यामुळे डाऊन सिंड्रोम येते. डाऊन सिंड्रोम कारण त्याला विशिष्ट पण आईचे वय 35च्या वर किंवा फार कमी असल्यास शक्यता टाळण्यासाठी रक्त तपासणी, आपण म्हणतो ट्रिपल टेस्ट, सोनोग्राफी, हे सगळे चाचणी करून आपल्याला समजू शकतो. समाजाची जबाबदारी अशी आहे की या मुलांना स्वीकारणे आणि शाळामधून प्रवेश देणे वेळेच्या वेळेला त्या डॉक्टरांच्याकडे घेऊन जाऊन उपचार करणे, कारण हार्टचा प्रॉब्लेम असू शकते. याच्या डॉक्टर आणि पालकांच्या दोघांच्या जबाबदारी असते. ऑक्युपेशनल थेरपी फार महत्वाची असते.
नमस्कार. डाऊन सिंड्रोम आपण डिसेबल्ड चाइल्ड डिफरंटली एबल्ड किंवा स्पेशल चाइल्ड म्हणतात. या आजाराची प्रमुख लक्षणे म्हणजे बाळाची वाढ, मेंदूची वाढ कमी होणे, साधारणपणे ते बाळ बाहुलीसारखे कायम चकमक आणि मुबक दिसते. गोल चेहरा, पाठीमागून बसके नाक, आणि त्यामुळे एकमेकांपासून लांब वाटणारे आणि दीर्घ डोळे, लहान तोंडाची खोली आणि त्यामुळेच मोठी वाटणारी आणि सतत बाहेर डोकावणारी जीभ, अशा विशिष्ट चेहऱ्याच्या ठेवणीमुळे हे बाळ सगळ्यांपेक्षा उठून दिसते.
छोटी मानवात काही प्रमाणात त्वचा, मृदू उंची, छोटे हात, पायाची हाताची विशिष्ट प्रमाणाची ठेवण, चिडचिडपणे अशी लक्षणे डाऊन सिंड्रोम सोबत येणारे इतर आजार, जन्माचा हृदयाची वेळ, आजाराची आणि त्या काळाची
बहुतेक स्त्रियांमध्ये 14 ते 16 आठवडे STD OHCG या तपासणी केल्यास 16 आठवड्यातच डाऊन सिंड्रोमचे निदान होऊ शकते. याला परिवेश असे म्हणतात. तसेच 18 ते 20 आठवड्यात सोनोग्राफीच्या माध्यमातून सगळ्यांकडून निदान होऊ शकते. सहसा आधी डाऊनचे बाळ जन्माला आल्यास 30 वर्षापेक्षा जास्त वय असलेल्या आईला या टेस्ट करण्याचा सल्ला दिला जातो.
डॉक्टर समाज याने हाताचा कळून उपचार केले तर डाऊन सिंड्रोमचे बाळ चांगले आयुष्य जगू शकते. डाऊन सिंड्रोमला जोडून येणाऱ्या आजाराची पडताळणी ही उपचाराची पहिली पायरी असते. म्हणून हृदय आजाराची 2D इको, मानेचा एक्सरे, थायरॉइडचे टेस्ट हा उपचाराचा महत्वाचा भाग असतो. नियमित फिजिओथेरपी, ऑक्युपेशनल थेरपी डाऊन सिंड्रोम मध्ये दिल्याने त्यांचे आयुष्य चांगले होते अशी कितीतरी उदाहरणे आहेत.
डॉक्टर, पालक व समाज यांनी समजून घे योग्य पद्धतीने डाऊन सिंड्रोमच्या व्यक्तींवर उपाय करणे गरजेचे आहे. नियमित पद्धतीने डॉक्टरांच्या सल्ल्याने फिजिओथेरपी व ऑक्युपेशनल थेरपी घेतल्यास डाऊन सिंड्रोम असणाऱ्या मुलांमध्ये याशिवाय मुलांना त्यांचे काम शिकवता येते. त्यांच्यासाठी वेगवेगळ्या शाळा असून त्यांना योग्य शिक्षण देणे व योग्य पद्धतीने त्यांना समजून वाढवल्यास, त्यांना समाजात योग्य स्थान दिल्यास या मुलांना समाजात जगणे अधिक सोयीस्कर होऊ शकते. आमच्या सह आहार आमच्यासाठी नाही या थीमनुसार डाऊन सिंड्रोम असणाऱ्या मुलांची वाढल्यास त्यांच्यात नक्कीच बदल होऊ शकतो. धन्यवाद.
डाऊन सिंड्रोम 21 मार्च हा जागतिक डाऊन सिंड्रोम दिवस आहे. IAP सांगली ब्रांचच्या वतीने आम्ही देखील हा दिवस साजरा करायचा ठरवलेला आहे. सांगली जिल्ह्यातील सर्व पेडियाट्रिशियन मिळून आम्ही ह्या स्पेशल चिल्ड्रन डाऊन सिंड्रोमच्या पोरांना स्पेशल चिल्ड्रन म्हणून संबोधित केले गेलेलं आहे. ह्या पोरांना सर्वसामान्य जीवनात मेन स्ट्रीमलाईन ऑफ सोसायटी मध्ये कसं आपल्याला अकोमोडेट करता येते ह्या दृष्टिकोनातून आम्ही सर्वजण प्रयत्नशील आहोत आणि ह्या पोरांच्या मदतीसाठी आम्ही सर्वजण कटिबद्ध आहोत.
डाऊन सिंड्रोमच्या मुलांना समाजाच्या मुख्य प्रवाहात आणण्यासाठी इतर मुलांप्रमाणे शिक्षण असेल, कला, क्रीडा किंवा इतर कामांमध्ये इक्वल संधी मिळाल्या पाहिजे. आणि यासाठीच आम्ही विथ अस नॉट फॉर अस या कॅम्पेनद्वारे सर्व समाजाला आव्हान करतो की यांना सिम्पॅथेटिक दृष्टीने बघण्यापेक्षा त्यांना एम्पॅथेटिक दृष्टीने त्यांच्या स्वतःच्या पायावर उभा करण्यासाठी सर्वांनी मदत करावी.
On the occasion of Down Syndrome Day, I want to dedicate some lines to Down Syndrome angels. This child may not be perfect in the eyes of earthly man, but God designed this child according to His plan, perhaps to serve as inspiration to those who have it all, to recognize their limitation in comparison are small. The almond-shaped eyes of those born with down embrace life to its fullest. The sights and the sound, aware of the things most people are not, with childlike innocence that most adults have forgot. So God sent these angels to teach all of us here that these unsung heroes have lessons to share. Thank you.
Yes. Thank you so much. Yes. So now coming to the next section. I don't know we are getting late a bit, but without this video, which were Dr. Guru sir posted today morning. I would like to know that PG students are sitting for this for them also, please.
So as March were down today. Another bar. त्या दिवसांनी तर आज आपल्याला आम्ही दोन शब्द डाऊन सिंड्रोम बद्दल बोलू इच्छितो. डाऊन सिंड्रोम हा आजार किती घातक आहे किंवा त्याचे साईड इफेक्ट आहेत, त्याचे प्रॉब्लेम्स किती आहेत हे आपल्या सर्वांना माहिती आहे. डाऊन सिंड्रोम हा आजार डायग्नोसिस करणं फार अवघड नाही, स्मार्ट डायग्नोसिस आहे. बरेचसे एक्सपेरिमेंट फीचर्स सगळ्यांना माहित आहे. आपल्या सर्व मित्रांनी पण आज सांगितलेले आहेतच. परंतु हा किती घातक आजार आहे हे पाहण्यासाठी पण इंटरनल प्रॉब्लेम इफेक्ट्स काय हे पण आपल्याला माहिती पाहिजे. फॉर एक्झाम्पल congenital heart disease, ADHD, heart failure, life expectancy कमी असते. अल्झायमर डिसीज सारखा आजार नॉर्मली 80 च्या आसपास होतो, पण डाऊन सिंड्रोम मध्ये तो आजार त्यामुळं अशा पेशंटला पुढं थोडंसं लाईफ जगणं खूप अवघड होते. अशा पद्धतीचे पेशंट निर्माण होऊ नये त्याचीच काळजी घ्यायला पाहिजे असं मला वाटतंय. तर यासाठी काय करायला लागेल, अँटीनेटल डायग्नोसिस करणं आवश्यक आहे. अँटीनेटल डायग्नोसिस जर वेळेस आपण केलं, फॉर एक्झाम्पल जर आपण maternal serum alpha त्यामध्ये नेमकं ट्रान्सफॉर्मेशनची मोर दॅन 3 मिनिट दाखवते. आणि थोडस पुढे जाऊन 15-16 आठवड्याच्या दरम्यान प्रेग्नन्सीमध्ये जर आपण इनिक्विन लेवल तर विटायसिस आणि इनिक्विन लेवल वाढले कमी झाले. अशा वेळेला 99% डायग्नोसिस. त्याच वेळेला जर आपण शॉपरिंग केलं आणि अवयवशक्तीचा निर्णय घेतला तर आपल्याला डायग्नोसिस करता येईल.
Thank you so much. Thank you for your patience listening. Thank you. Now going further, एकच मिनिट फक्त. भूक लागली मला बघा. ऍक्च्युली ओबेसिटी क्लिनिक आपलं जे आता लेक्चर झालं त्यामध्ये आपल्या ज्ञान डॅशिंग मॅडम डॉक्टर राक्षणी मॅडमने चांगला खूप एक शॉर्ट स्पॅन ऑफ टाइम त्यांनी खूप चांगलं जे टॉक दिलेला आहे आणि त्याच्यासाठी त्यांना प्रेझेंटेशन करणं गरजेचंच आहे. I request Dr. Rakshana Madam please to come on the dais. I request Dr. Wagh sir to please. Thank you so much.
Actually, I would like to say special thanks to Matin sir and Harshal sir for encouraging me to participate, and also I thank Sangli IAP for giving me the opportunity.
Thank you so much for kind words, ma'am. And without this, what we have put together, without Harshal, आतापर्यंतचे 3 जे आपले जे मीटिंग झाले ते लाईव्ह झाले. आता कोणतीही IAP ची टीम ऑल ओव्हर इंडियाने केलेलं नाहीये. दिस इज अ क्रेडिट. आणि आता जो व्हिडिओ झालेला आहे आपण घेतलेला आहे त्याच्यासाठी स्क्रिप्ट पासून ते एडिटिंग पासून एव्हरीथिंग अँड ते सेंटरला पोहोचवण्याचं काम पण हर्षलनेच केलंय. आय थिंक त्याला आपली बिग क्लॅप द्यायलाच पाहिजे. आणि त्याच्यासाठी एक प्रोत्साहन म्हणून आम्ही आमच्या भाषेत त्याला हौसला एक्झाईट म्हणतो. आय रिक्वेस्ट हर्षल टू बी ऑन द डॅश. व्हॉट्सअप प्लीज बी ऑफिशियल प्लेयर आहात. प्लीज बी ऑन द डॅश. प्लीज बी ऑन द डॅश. डॉक्टर अन्नापरे सर प्लीज कम अँड प्रेसिडेंट प्लीज सर. हर्षल. Sir, yeah. Yes. Thank you so much. Yes.
Just 30 minutes back, I got a message from Dr. Samir Talwai, sir. The video that we have made has reached Central IAP as well as MAHAIAP. And Dr. Amol Pawar, sir, who is Secretary of MAHAIAP, has appreciated and has shared the video with all the branches. And also, sir, got a message from Kalatkar, sir, as well. That the video has reached everyone and they have appreciated us. Thank you, sir.
Thank you.